1. What is the primary pathophysiological hallmark of non-alcoholic fatty liver disease, NAFLD? A. Insulin sensitivity in hepatocytes. B. Excess triglyceride accumulation in hepatocytes. C. Chronic alcohol consumption. D. Viral infection of liver cells. Answer: excess triglyceride accumulation in hepatocytes. Rationale: NAFLD is primarily characterized by excessive triglyceride accumulation in liver cells due to altered lipid metabolism and insulin resistance. Option A is incorrect because insulin resistance, not sensitivity, is a key factor. Option C is incorrect as NAFLD is unrelated to alcohol use. Option D is incorrect as NAFLD is not caused by viral infections. 2. Which patient is at the highest risk of developing NAFLD? A. A 45-year-old with a BMI of 32 and type 2 diabetes. B. A 25-year-old with normal weight and no comorbidities. C. A 60-year-old with a history of alcohol abuse. D. A 50-year-old with a viral hepatitis infection. Answer: a 45-year-old with a BMI of 32 and type 2 diabetes. Rationale: obesity and type 2 diabetes are the most significant risk factors for NAFLD due to insulin resistance and metabolic syndrome. Option B is incorrect because NAFLD is less likely in a healthy individual without risk factors. Option C is incorrect as alcohol abuse causes alcoholic fatty liver disease, not NAFLD. Option D is incorrect because viral hepatitis is unrelated to NAFLD development. 3. What is the gold standard for diagnosing non-alcoholic steatohepatitis, NASH, a severe form of NAFLD? A. Liver biopsy. B. Ultrasound. C. Serum liver enzyme levels. D. Computed tomography (CT) scan. Answer: liver biopsy. Rationale: liver biopsy is the gold standard for diagnosing NASH because it provides definitive information on inflammation, fibrosis, and fat accumulation. Option B, ultrasound, is non-invasive but cannot differentiate between simple steatosis and NASH. Option C, serum liver enzymes, may be elevated but are nonspecific. Option D, CT scan, can detect steatosis but does not provide histological details. 4. Which lifestyle modification is most effective for managing NAFLD in overweight patients? A. Low-fat diet. B. Weight loss of 3% to 5% of total body weight. C. Exercise without dietary changes. D. Intermittent fasting. Answer: weight loss of 3% to 5% of total body weight. Rationale: a weight loss of 3% to 5% has been shown to significantly reduce liver fat accumulation in NAFLD patients, while 7% to 10% may improve fibrosis. Option A, low-fat diet, is not as effective as targeted weight loss. Option C, exercise without dietary changes, may improve liver health, but is less effective without weight loss. Option D, intermittent fasting, can help in weight loss, but is not universally recommended for NAFLD management. 5. What is a potential long-term complication of untreated NAFLD? A. Hepatocellular carcinoma. B. Peptic ulcer disease. C. Cholecystitis. D. Pancreatitis. Answer: hepatocellular carcinoma. Rationale: untreated NAFLD can progress to cirrhosis, which increases the risk of hepatocellular carcinoma. Option B, peptic ulcer disease. Option C, cholecystitis. And Option D, pancreatitis, are unrelated to NAFLD. 6. Which imaging modality is typically the first line for detecting fatty liver in suspected NAFLD cases? A. MRI. B. Ultrasound. C. CT scan. D. PET scan. Answer: ultrasound. Rationale: ultrasound is non-invasive, cost-effective, and commonly used as the first-line imaging technique for detecting fatty liver. Option A, MRI, is more sensitive but not used routinely. Option C, CT scan, can detect fat but involves radiation exposure. Option D, PET scan, is not used for fatty liver diagnosis. 7. Which metabolic condition is most strongly associated with the development of NAFLD? A. Hypothyroidism. B. Type 2 diabetes mellitus. C. Hyperthyroidism. D. Addison's disease. Answer: type 2 diabetes mellitus. Rationale: type 2 diabetes is a major risk factor for NAFLD due to its association with insulin resistance and metabolic syndrome. Option A, hypothyroidism, can contribute but is less common. Option C, hyperthyroidism, and Option D, Addison's disease, are not typically associated with NAFLD. A. What laboratory finding is most commonly associated with NAFLD? A. Elevated ALT and AST. B. Low albumin levels. C. Decreased total bilirubin. D. Elevated alkaline phosphatase. Answer: elevated ALT and AST. Rationale: elevated ALT and AST are common in NAFLD, with ALT often being higher than AST in early stages. Option B, low albumin, and Option C, low bilirubin, are not typical of NAFLD. Option D, alkaline phosphatase, may be elevated but is less specific. 9. Which dietary change is most beneficial for patients with NAFLD? A. High-protein diet. B. Mediterranean diet. C. Low-carbohydrate diet. D. Ketogenic diet. Answer: Mediterranean diet. Rationale: the Mediterranean diet, rich in healthy fats, fruits, vegetables, and whole grains, has been shown to improve liver health in NAFLD patients. Option A, high protein, and Option C, low carbohydrate, may not provide comprehensive benefits. Option D, ketogenic diet, may lead to rapid weight loss, but is not widely recommended for NAFLD management. 10. What is a defining feature of non-alcoholic steatohepatitis, NASH, compared to simple steatosis? A. Liver fibrosis. B. Presence of inflammation and hepatocyte injury. C. Portal hypertension. D. Jaundice. Answer: presence of inflammation and hepatocyte injury. Rationale: NASH involves inflammation and hepatocyte damage, distinguishing it from simple steatosis. Option A, fibrosis, may occur but is not the defining feature. Option C, portal hypertension, and Option D, jaundice, are complications of advanced liver disease, not specific to NASH. 11. Which pharmacological treatment is recommended for NAFLD? A. Pioglitazone. B. Metformin. C. Aspirin. D. Statins. Answer: pioglitazone. Rationale: pioglitazone, a PPAR gamma agonist, has been shown to improve liver histology in some NAFLD patients, particularly those with NASH. Option B, metformin, has limited evidence for NAFLD-specific benefits. Option C, aspirin, and Option D, statins, are not used as direct treatments for NAFLD. 12. What is the most effective non-pharmacological intervention for NAFLD management? A. Reducing alcohol intake. B. Weight loss through diet and exercise. C. Increasing protein intake. D. Taking omega-3 supplements. Answer: weight loss through diet and exercise. Rationale: weight loss through a combination of diet and exercise is the cornerstone of NAFLD management, significantly reducing liver fat and improving outcomes. Option A, alcohol reduction, is irrelevant as NAFLD is non-alcoholic. Option C, increasing protein, and Option D, omega-3, may have minor benefits but are not primary interventions. 13. What percentage of body weight loss is generally required to improve fibrosis in NAFLD? A. 3% to 5%. B. 5% to 7%. C. 7% to 10%. D. 10% to 15%. Answer: 7% to 10%. Rationale: a 7% to 10% weight loss is associated with significant improvement in liver fibrosis in NAFLD patients. Option A, 3% to 5%, may reduce fat accumulation but is insufficient for fibrosis improvement. Options B and D represent less common benchmarks for fibrosis-specific changes. 14. Which complication is most commonly associated with untreated NAFLD? A. Cirrhosis. B. Peptic ulcer disease. C. Gallstones. D. Pancreatitis. Answer: cirrhosis. Rationale: untreated NAFLD can progress to cirrhosis due to persistent inflammation and fibrosis. Options B, peptic ulcer, C. Gallstones, and D. Pancreatitis, are unrelated to NAFLD complications. 15. What role does insulin resistance play in the pathogenesis of NAFLD? A. Inhibits lipid storage in hepatocytes. B. Promotes lipid accumulation in hepatocytes. C. Decreases hepatic glucose production. D. Reduces inflammation in liver tissue. Answer: promotes lipid accumulation in hepatocytes. Rationale: insulin resistance leads to increased free fatty acid delivery to the liver and lipid accumulation in hepatocytes. Option A is incorrect because insulin resistance promotes, rather than inhibits, lipid storage. Option C is incorrect as insulin resistance increases hepatic glucose production. Option D is incorrect as it exacerbates inflammation rather than reducing it. 16. Which scoring system is often used to assess fibrosis in NAFLD patients? A. Child-Pugh score. B. MELD score. C. Fibrosis for Index, FIB4. D. Apache 2 score. Answer: Fibrosis for Index, FIB4. Rationale: the Fibrosis for Index, FIB4, is commonly used for non-invasive assessment of liver fibrosis in NAFLD patients. Option A, Child-Pugh, is for liver function in cirrhosis. Option B, MELD, assesses end-stage liver disease. Option D, Apache 2, is for critical care patients. 17. What histological feature differentiates NAFLD from alcoholic liver disease? A. Lobular inflammation. B. Ballooning degeneration of hepatocytes. C. Presence of Mallory-Dank bodies. D. Paravenular fibrosis. Answer: ballooning degeneration of hepatocytes. Rationale: ballooning degeneration of hepatocytes is a hallmark of NAFLD, especially in NASH. Option C, Mallory-Dank bodies, can occur in both conditions, but is more prominent in alcoholic liver disease. Options A and D are nonspecific findings. 18. Which hormone is most closely associated with the development of insulin resistance in NAFLD? A. Leptin. B. Ghrelin. C. Adiponectin. D. Insulin. Answer: adiponectin. Rationale: low levels of adiponectin are associated with increased insulin resistance and lipid accumulation in NAFLD. Option A, leptin, regulates appetite. Option B, ghrelin, is related to hunger signaling. Option D, insulin, is affected by, rather than causing, NAFLD-related resistance. 19. Which liver enzyme ratio is more common in advanced NAFLD? A. AST alt. B. Alt AST. C. Elevated alkaline phosphatase. D. Normal AST and ALT levels. Answer: AST alt. Rationale: in advanced NAFLD, as fibrosis progresses, the AST/ALT ratio often exceeds 1. In earlier stages, ALT AST is typical. Option C, alkaline phosphatase, is less specific, and option D, normal levels, does not indicate NAFLD progression. 20. Which lifestyle intervention is most effective in preventing NAFLD in high-risk populations? A. Engaging in daily high-intensity exercise. B. Following a low-fat diet exclusively. C. Regular moderate exercise and a balanced diet. D. Reducing salt intake significantly. Answer: regular moderate exercise and a balanced diet. Rationale: moderate exercise combined with a balanced diet is the most effective prevention strategy. High-intensity exercise, option A, may not be sustainable for all. Option B, low-fat diet, neglects overall balance, and option D, reducing salt, does not directly address NAFLD risk factors. 21. What is the primary function of liver biopsy in NAFLD management? A. Confirm cirrhosis. B. Diagnose NASH and assess fibrosis stage. C. Detect viral hepatitis. D. Evaluate bile duct obstruction. Answer: diagnose NASH and assess fibrosis stage. Rationale: liver biopsy remains the gold standard for diagnosing NASH and determining fibrosis stage. Option A, confirm cirrhosis, can often be done with non-invasive tests. Options C and D are unrelated to NAFLD-specific biopsy indications. 22. Which population group is at the highest risk of developing NAFLD? A. Young adults with active lifestyles. B. Postmenopausal women. C. Obese individuals with metabolic syndrome. D. Individuals following a ketogenic diet. Answer: obese individuals with metabolic syndrome. Rationale: obesity and metabolic syndrome are key risk factors for NAFLD. Option A, young adults, and Option D, ketogenic diet, are not typically associated with increased risk. Postmenopausal women, Option B, may have increased risk, but it is not as significant as metabolic syndrome. 23. What is the significance of transient elastography in NAFLD? A. Measures liver inflammation. B. Detects hepatocyte apoptosis. C. Assesses liver stiffness and fibrosis. D. Identifies biliary obstruction. Answer: assesses liver stiffness and fibrosis. Rationale: transient elastography, e.g., FibroScan, is a non-invasive technique to assess liver stiffness, indicating fibrosis. Options A and B do not describe elastography's function. Option D relates to a different diagnostic approach. 24. Which factor is considered protective against NAFLD? A. Moderate alcohol consumption. B. Active physical exercise. C. High dietary sugar intake. D. Sedentary lifestyle. Answer: active physical exercise. Rationale: regular physical activity reduces the risk of developing NAFLD. Options A. Alcohol consumption, C. High sugar intake, and D. Sedentary lifestyle are associated with an increased risk. 25. How does obesity contribute to NAFLD development? A. Increases bile acid production. B. Promotes insulin resistance and lipogenesis. C. Lowers circulating triglycerides. D. Reduces systemic inflammation. Answer: promotes insulin resistance and lipogenesis. Rationale: obesity promotes insulin resistance, leading to increased lipid synthesis, lipogenesis, in the liver. Options A, C, and D are not accurate descriptions of obesity's impact on NAFLD pathogenesis. 26. What type of diet is recommended for patients with NAFLD to reduce liver fat? A. High-protein, low-fat diet. B. Mediterranean diet. C. Ketogenic diet. D. High-carbohydrate diet. Answer: Mediterranean diet. Rationale: the Mediterranean diet, rich in unsaturated fats, fruits, vegetables, and lean proteins, has been shown to improve liver health and reduce liver fat. Option A, high-protein, low-fat diet, may not target NAFLD specifically. Options C and D, ketogenic and high-carbohydrate diets, can have mixed effects on liver fat. 27. Which extrahepatic condition is most commonly associated with NAFLD? A. Osteoporosis. B. Cardiovascular disease. C. Chronic kidney disease. D. Rheumatoid arthritis. Answer: cardiovascular disease. Rationale: NAFLD is closely associated with cardiovascular disease due to shared risk factors like obesity, diabetes, and dyslipidemia. Options A, C, and D are less directly linked to NAFLD compared to cardiovascular complications. 28. In NAFLD, elevated levels of which biomarker indicate oxidative stress and inflammation? A. Ferritin. B. Alkaline phosphatase. C. Bilirubin. D. Albumin. Answer: ferritin. Rationale: elevated ferritin levels in NAFLD can indicate oxidative stress and inflammation. Option B, alkaline phosphatase, is not specific for NAFLD. Option C, bilirubin, and Option D, albumin, are not markers of oxidative stress or inflammation. 29. What is the primary goal of treatment for patients with NAFLD? A. Achieve rapid weight loss. B. Reverse fibrosis within 1 month. C. Prevent disease progression and improve liver health. D. Initiate antiviral therapy. Answer: prevent disease progression and improve liver health. Rationale: the main goal of treatment for NAFLD is to halt progression to more severe liver diseases like cirrhosis and improve overall liver health. Options A and B focus on unrealistic or potentially harmful interventions. Option D, antiviral therapy, is not applicable to NAFLD. 30. Which imaging modality provides the best non-invasive assessment of liver fat in NAFLD? A. CT scan. B. MRI-PDFF. C. Abdominal X-ray. D. PET scan. Answer: MRI-PDFF. Rationale: MRI-PDFF, proton density fat fraction, is highly accurate for measuring liver fat content in NAFLD. Option A, CT scan, is less sensitive. Option C, X-ray, and D, PET scan, are not used to assess liver fat. 31. What does the NAFLD activity score, NAS, assess? A. Hepatocellular carcinoma risk. B. Inflammation and fibrosis. C. Degree of steatosis, inflammation, and ballooning. D. Portal hypertension severity. Answer: degree of steatosis, inflammation, and ballooning. Rationale: NAS is used to evaluate the severity of histological changes in NAFLD, including steatosis, inflammation, and hepatocyte ballooning. Option B only partially describes NAS, while options A and D are unrelated. 32. What percentage of liver fat is typically required for a diagnosis of steatosis via biopsy? A. 1%. B. 5%. C. 10%. D. 20%. Answer: 5%. Rationale: a liver biopsy confirming greater than or equal to 5% of hepatocytes containing fat is required for diagnosing hepatic steatosis. Options A, C, and D are either too low or too high. 33. Which pharmacologic agent is considered investigational for NAFLD treatment? A. Metformin. B. Pioglitazone. C. Obeticholic acid. D. Ursodeoxycholic acid. Answer: obeticholic acid. Rationale: obeticholic acid is under investigation for treating NASH/NAFLD. Pioglitazone, option B, has some evidence for use. Options A, metformin, and D, ursodeoxycholic acid, are less effective for NAFLD-specific treatment. 34. What is a potential complication of advanced NAFLD? A. Gallstones. B. Hepatocellular carcinoma. C. Bile duct strictures. D. cholangitis. Answer: hepatocellular carcinoma. Rationale: advanced NAFLD can lead to cirrhosis, significantly increasing the risk of hepatocellular carcinoma. Options A, C, and D are not direct complications of NAFLD. 35. Which population should be screened for NAFLD? A. Healthy teenagers. B. Obese adults with diabetes or metabolic syndrome. C. Competitive athletes. D. Individuals without any risk factors. Answer: obese adults with diabetes or metabolic syndrome. Rationale: screening is recommended for those at high risk, such as obese individuals with diabetes or metabolic syndrome. Options A, C, and D do not represent at-risk populations. 36. What role does vitamin E play in NAFLD management? A. Antioxidant therapy to reduce liver inflammation. B. Improves insulin sensitivity. C. Directly reduces liver fibrosis. D. Promotes rapid weight loss. Answer: antioxidant therapy to reduce liver inflammation. Rationale: vitamin E, as an antioxidant, helps reduce inflammation in NAFLD. Option B, improves insulin sensitivity, is not its primary role. Option C, fibrosis reduction, and Option D, rapid weight loss, are unrelated. 37. Which factor is not a component of the metabolic syndrome contributing to NAFLD? A. Abdominal obesity. B. Hypertriglyceridemia. C. Hyperglycemia. D. Hypotension. Answer: hypotension. Rationale: hypotension is not a component of metabolic syndrome. Abdominal obesity, hypertriglyceridemia, and hyperglycemia are key contributors to NAFLD. 38. Which is the first-line imaging technique for NAFLD diagnosis? A. Ultrasound. B. MRI. C. CT scan. D. Fibroscan. Answer: ultrasound. Rationale: ultrasound is the preferred first-line imaging for NAFLD due to its accessibility and sensitivity to detecting fatty infiltration. Options B, C, and D are used for further evaluation or specialized cases. 39. What is the primary indication for bariatric surgery in NAFLD patients? A. Advanced fibrosis with NASH. B. Severe obesity with comorbidities. C. Refractory ascites. D. Mild obesity with steatosis. Answer: severe obesity with comorbidities. Rationale: bariatric surgery is indicated for severe obesity with related comorbidities like diabetes in NAFLD patients. Options A, C, and D are incorrect or incomplete indications. 40. What is the long-term risk of untreated NASH? A. Recurrent gallbladder disease. B. Cirrhosis and liver failure. C. Hepatic adenoma. D. Autoimmune hepatitis. Answer: cirrhosis and liver failure. Rationale: untreated NASH can progress to cirrhosis, increasing the risk of liver failure. Options A, C, and D are not typical long-term risks associated with untreated NASH. 41. What is the most common histological finding in NAFLD? A. Hepatocyte ballooning. B. Necroinflammation. C. Steatosis. D. Fibrosis. Answer: steatosis. Rationale: steatosis, fat accumulation in hepatocytes, is the most common histological finding in NAFLD. Ballooning, option A, and fibrosis, option D, can occur in more advanced stages, while necroinflammation, option B, is a feature of NASH, not all cases of NAFLD. 42. Which medication is commonly used to manage the insulin resistance seen in NAFLD? A. Metformin. B. Prednisone. C. Methotrexate. D. Warfarin. Answer: metformin. Rationale: metformin is commonly used to manage insulin resistance, a key feature of NAFLD. Options B, C, and D are not effective treatments for insulin resistance or NAFLD. 43. Which liver enzyme is typically elevated in NAFLD? A. Alkaline phosphatase. B. Aspartate aminotransferase, AST. C. Amylase. D. Gamma-glutamyl transferase, GGT. Answer: aspartate aminotransferase, AST. Rationale: AST is often elevated in NAFLD, especially in cases of steatosis or NASH. Alkaline phosphatase, option A, may also be mildly elevated, but is less specific. Amylase, option C, and GGT, option D, are not typically elevated in NAFLD. 44. What is the most significant risk factor for developing NAFLD? A. Excessive alcohol consumption. B. Obesity. C. Hepatitis B infection. D. Smoking. Answer: obesity. Rationale: obesity is the most significant risk factor for developing NAFLD due to its association with insulin resistance and metabolic syndrome. While alcohol, option A, can cause liver damage, it is not a primary risk factor for NAFLD. Hepatitis B, option C, and smoking, option D, are less strongly linked to NAFLD. 45. Which of the following is a potential complication of cirrhosis due to NAFLD? A. Pancreatitis. B. Portal hypertension. C. Peptic ulcers. D. Chronic kidney disease. Answer: portal hypertension. Rationale: portal hypertension is a common complication of cirrhosis, often seen in patients with advanced NAFLD. Pancreatitis, option A, peptic ulcers, option C, and chronic kidney disease, option D, are not direct complications of cirrhosis in NAFLD. 46. Which screening test is recommended for NAFLD in patients with risk factors? A. Liver biopsy. B. Fibroscan. C. Chest X-ray. D. Colonoscopy. Answer: Fibroscan. Rationale: Fibroscan is a non-invasive imaging technique used to assess liver stiffness and diagnose fibrosis in NAFLD. Liver biopsy, option A, is more invasive and typically reserved for uncertain cases. Chest X-ray, option C, and colonoscopy, option D, are unrelated to NAFLD screening. 47. Which of the following is not a typical clinical feature of NAFLD? A. Jaundice. B. Fatigue. C. Abdominal discomfort. D. Hepatomegaly. Answer: jaundice. Rationale: Jaundice is not typically seen in NAFLD unless the disease progresses to cirrhosis or other complications. Fatigue, option B, abdominal discomfort, option C, and hepatomegaly, option D, are common in NAFLD. 48. What lifestyle change is most beneficial in the management of NAFLD? A. Increased alcohol consumption. B. Weight loss through diet and exercise. C. Complete bed rest. D. Increased sugar intake. Answer: weight loss through diet and exercise. Rationale: weight loss through a balanced diet and exercise is the most effective lifestyle change for managing NAFLD. Increased alcohol consumption, option A, and sugar intake, option D, can worsen NAFLD, while complete bed rest, option C, is not recommended. 49. What is the primary treatment goal for patients with NASH, the most severe form of NAFLD? A. Cure the disease. B. Prevent progression to cirrhosis and liver failure. C. Relieve symptoms of abdominal pain. D. Reduce cholesterol levels. Answer: prevent progression to cirrhosis and liver failure. Rationale: the primary treatment goal for NASH is to prevent its progression to cirrhosis and liver failure. Options A, C, and D are secondary to this primary goal. 50. What is the role of bariatric surgery in treating NAFLD? A. That is a first-line treatment. B. It helps in weight loss and improves liver function. C. It cures the disease permanently. D. It prevents all liver complications. Answer: it helps in weight loss and improves liver function. Rationale: bariatric surgery is helpful in managing obesity and improving liver function in NAFLD patients. However, it is not first-line, option A, and does not cure NAFLD, option C. It also does not prevent all complications, option D. 51. Which of the following is the most common cause of NAFLD in children? A. Hepatitis C. B. Obesity. C. Alcohol abuse. D. Genetic liver disease. Answer: obesity. Rationale: obesity is the most common cause of NAFLD in children, as it is a significant contributor to insulin resistance and metabolic syndrome. Hepatitis C, option A, alcohol abuse, option C, and genetic liver disease, option D, are less common causes. 52. Which of the following is not a risk factor for the progression of NAFLD to NASH? A. Obesity. B. Type 2 diabetes. C. High-fiber diet. D. Male gender. Answer: high-fiber diet. Rationale: a high-fiber diet is not a risk factor for the progression of NAFLD to NASH. In contrast, obesity, diabetes, and male gender are all risk factors for progression to NASH. 53. Which laboratory test is most useful in diagnosing NAFLD? A. Hepatitis C PCR test. B. Liver function tests. C. Alpha-fetoprotein AFP levels. D. Serum ferritin levels. Answer: liver function tests. Rationale: liver function tests help assess the degree of liver damage in NAFLD. While the hepatitis C PCR test, option A, is useful for hepatitis C, AFP, option C, and ferritin, option D, are not diagnostic for NAFLD. 54. Which of the following factors is most likely to improve the prognosis of NAFLD? A. Regular physical activity. B. Alcohol consumption. C. High sugar diet. D. Lack of medical management. Answer: regular physical activity. Rationale: regular physical activity is a key factor in improving the prognosis of NAFLD by reducing liver fat and improving metabolic health. Alcohol consumption, option B. A high sugar diet, option C, and lack of medical management, option D, can worsen NAFLD. 55. Which of the following is not typically included in the management plan for NAFLD? A. Lifestyle modifications. B. Statin therapy for cholesterol control. C. Antiviral medications. D. Diabetes management. Answer: antiviral medications. Rationale: antiviral medications are not typically used to treat NAFLD, as it is not caused by a viral infection. Lifestyle modifications, statin therapy, and diabetes management are common elements of NAFLD management. 56. Which of the following is a hallmark feature of NASH compared to simple NAFLD? A. Hepatomegaly. B. Hepatic fibrosis. C. Steatosis. D. Increased AST/ALT ratio. Answer: hepatic fibrosis. Rationale: hepatic fibrosis is a hallmark of NASH, distinguishing it from simple NAFLD, which is characterized primarily by steatosis, option C. Hepatomegaly, option A, and an increased AST/ALT ratio, option D, may occur but are not specific to NASH. 57. Which dietary approach is commonly recommended for NAFLD patients? A. High-protein, low-fat diet. B. Mediterranean diet. C. High-carb, low-protein diet. D. Low-sodium diet. Answer: Mediterranean diet. Rationale: the Mediterranean diet, rich in fruits, vegetables, healthy fats, and whole grains, is commonly recommended for patients with NAFLD. High-protein, low-fat, option A, and high-carb, low-protein, option C, diets are not recommended. Low-sodium diets, option D, are not particularly relevant for NAFLD. 58. What is the first-line diagnostic tool for evaluating liver stiffness in NAFLD patients? A. CT scan. B. Ultrasound. C. MRI. D. Fibroscan. Answer: Fibroscan. Rationale: Fibroscan is the first-line diagnostic tool for evaluating liver stiffness, which can indicate the degree of fibrosis in NAFLD patients. CT scan, option A, ultrasound, option B, and MRI, option C, are not typically used for this purpose. 59. Which of the following is a potential complication of cirrhosis secondary to NAFLD? A. Hepatic encephalopathy. B. Gallstones. C. Diverticulitis. D. Skin cancer. Answer: hepatic encephalopathy. Rationale: hepatic encephalopathy is a potential complication of cirrhosis, which can occur secondary to NAFLD. Gallstones, option B, diverticulitis, option C, and skin cancer, option D, are not typical complications of cirrhosis in NAFLD. 60. What is the recommended management strategy for a patient with advanced cirrhosis due to NAFLD? A. Liver transplant. B. Chemotherapy. C. Antibiotics for infection. D. Insulin therapy. Answer: liver transplant. Rationale: liver transplant is the recommended treatment for patients with advanced cirrhosis due to NAFLD when other management options fail. Chemotherapy, option B, antibiotics, option C, and insulin therapy, option D, are not appropriate treatments for cirrhosis secondary to NAFLD. 61. Which of the following is an essential feature of metabolic syndrome? A. Hypertension. B. Hyperthyroidism. C. Anemia. D. Hypercalcemia. Answer: hypertension. Rationale: hypertension is one of the key features of metabolic syndrome, along with hyperglycemia, dyslipidemia, and abdominal obesity. Hyperthyroidism, option B, anemia, option C, and hypercalcemia, option D, are not defining features of metabolic syndrome. 62. Which lipid abnormality is most commonly associated with metabolic syndrome? A. Low HDL cholesterol. B. High LDL cholesterol. C. High triglycerides. D. High total cholesterol. Answer: high triglycerides. Rationale: high triglycerides are a hallmark feature of metabolic syndrome. Low HDL, option A, and high LDL, option B, may also be present, but are less commonly associated with metabolic syndrome compared to high triglycerides. 63. What is the most effective non-pharmacologic treatment for managing metabolic syndrome? A. Physical activity and weight loss. B. Antihypertensive medications. C. Statin therapy. D. Insulin injections. Answer: physical activity and weight loss. Rationale: physical activity and weight loss are the most effective ways to manage metabolic syndrome and reduce associated risks, such as cardiovascular disease. Antihypertensive medications, option B, statins, option C, and insulin injections, option D, are not first-line treatments. 64. Which of the following is a major risk factor for the development of metabolic syndrome? A. Age greater than 50 years. B. Low carbohydrate diet. C. Insulin resistance. D. Regular physical exercise. Answer: insulin resistance. Rationale: insulin resistance is a major risk factor for developing metabolic syndrome, as it leads to several of the syndrome's components, including high blood sugar and triglycerides. Age: option A, low carbohydrate diet, option B, and regular physical exercise, option D, can help prevent metabolic syndrome but are not direct risk factors. 65. Which of the following is not a common feature of metabolic syndrome? A. Abdominal obesity. B. Elevated blood pressure. C. Increased physical activity. D. High blood glucose levels. Answer: increased physical activity. Rationale: increased physical activity is not a feature of metabolic syndrome. In fact, physical inactivity is a risk factor. Abdominal obesity, elevated blood pressure, and high blood glucose levels are common features of metabolic syndrome. 66. Which of the following medications is used to improve insulin sensitivity in patients with metabolic syndrome? A. Metformin. B. Aspirin. C. Omeprazole. D. Furosemide. Answer: metformin. Rationale: metformin is used to improve insulin sensitivity in patients with metabolic syndrome and type 2 diabetes. Aspirin, option B, omeprazole, option C, and furosemide, option D, are not used to address insulin resistance in metabolic syndrome. 67. What lifestyle change is most effective in reducing the risk of metabolic syndrome? A. Increasing alcohol consumption. B. Weight reduction through diet and exercise. C. High protein, low carbohydrate diet. D. Decreased fiber intake. Answer: weight reduction through diet and exercise. Rationale: weight reduction through diet and exercise is the most effective lifestyle change for reducing the risk of metabolic syndrome. Increasing alcohol consumption, option A, high protein, low carbohydrate diets, option C, and decreased fiber intake, option D, are not recommended. 68. Which of the following is a common complication of untreated metabolic syndrome? A. Gallstones. B. Stroke. C. Osteoporosis. D. Hearing loss. Answer: stroke. Rationale: stroke is a common complication of untreated metabolic syndrome due to its association with hypertension, diabetes, and other cardiovascular risk factors. Gallstones, option A, osteoporosis, option C, and hearing loss, option D, are not direct complications of metabolic syndrome. 69. What is the most important modifiable risk factor for cardiovascular disease in metabolic syndrome? A. Smoking. B. Physical inactivity. C. High sodium intake. D. High blood pressure. Answer: high blood pressure. Rationale: high blood pressure is one of the most important modifiable risk factors for cardiovascular disease in metabolic syndrome. Smoking, option A, physical inactivity, option B, and high sodium intake, option C, also contribute but are less critical compared to hypertension. 70. Which condition is most commonly associated with insulin resistance in metabolic syndrome? A. Celiac disease. B. Polycystic ovary syndrome, POS. C. Hyperthyroidism. D. Chronic obstructive pulmonary disease, COPD. Answer: polycystic ovary syndrome, POS. Rationale: polycystic ovary syndrome, POS, is commonly associated with insulin resistance and metabolic syndrome. Celiac disease, option A, hyperthyroidism, option C, and COPD, option D, are not strongly associated with insulin resistance. 71. Which of the following blood tests is most commonly used to assess insulin resistance? A. Hemoglobin A1C. B. C-reactive protein. C. Fasting glucose level. D. Fasting insulin level. Answer: fasting insulin level. Rationale: fasting insulin level is the most commonly used test to assess insulin resistance, as elevated insulin levels indicate impaired insulin sensitivity. Hemoglobin A1C, option A, and fasting glucose, option C, are used to assess blood sugar levels, not insulin resistance. C-reactive protein, option B, measures inflammation but is not specific to insulin resistance. 72. Which of the following is a potential long-term consequence of untreated metabolic syndrome? A. Chronic kidney disease. B. Asthma. C. Stroke. D. Rheumatoid arthritis. Answer: chronic kidney disease. Rationale: chronic kidney disease is a potential long-term consequence of untreated metabolic syndrome due to the increased risk of hypertension and diabetes. Asthma, option B. Stroke, option C, and rheumatoid arthritis, option D, are not as directly linked to metabolic syndrome. 73. What is the target goal for blood pressure in patients with metabolic syndrome? A. 140/90 mmHg. B. 130/80 mmHg. C. 120/70 mmHg. D. 110/60 mmHg. Answer: 130/80 mmHg. Rationale: the target goal for blood pressure in patients with metabolic syndrome is generally 130/80 mmHg. Blood pressure goals of 140/90 mmHg, option A, are used for less severe cases, and lower goals like 120/70 mmHg, option C, and 110/60 mmHg, option D, are often not recommended due to the risk of side effects. 74. Which of the following is not a common cause of insulin resistance? A. Obesity. B. Sedentary lifestyle. C. High-calorie diet. D. Hyperthyroidism. Answer: hyperthyroidism. Rationale: hyperthyroidism does not typically cause insulin resistance. Obesity, a sedentary lifestyle, and a high-calorie diet are all common causes of insulin resistance. 75. Which of the following is a feature of a high-sodium diet that contributes to metabolic syndrome? A. Increased insulin sensitivity. B. Elevated blood pressure. C. Decreased triglyceride levels. D. Increased HDL cholesterol. Answer: elevated blood pressure. Rationale: a high-sodium diet contributes to elevated blood pressure, which is a key feature of metabolic syndrome. It does not increase insulin sensitivity, option A, decrease triglyceride levels, option C, or increase HDL cholesterol, option D. 76. What is the primary goal of treatment for patients with metabolic syndrome? A. Weight loss and improvement in insulin sensitivity. B. Lowering cholesterol. C. Reducing liver enzymes. D. Improving lung function. Answer: weight loss and improvement in insulin sensitivity. Rationale: the primary goal of treatment for metabolic syndrome is weight loss and improvement in insulin sensitivity, which address the underlying causes of the syndrome. Lowering cholesterol, option B. Reducing liver enzymes, option C, and improving lung function, option D, are secondary goals. 77. Which of the following is a potential side effect of metformin in patients with metabolic syndrome? A. Weight gain. B. Hypoglycemia. C. Gastrointestinal distress. D. Hyperkalemia. Answer: gastrointestinal distress. Rationale: gastrointestinal distress, such as nausea and diarrhea, is a common side effect of metformin. Metformin typically does not cause weight gain, option A, hypoglycemia, option B, or hyperkalemia, option D. 78. Which of the following medications is typically used to control high blood pressure in metabolic syndrome? A. Beta blockers. B. ACE inhibitors. C. Statins. D. Diuretics. Answer: ACE inhibitors. Rationale: ACE inhibitors are commonly used to control high blood pressure in patients with metabolic syndrome. Beta blockers, option A, statins, option C, and diuretics, option D, may also be used but are not as commonly prescribed for hypertension in this context. 79. What dietary change is most effective in improving lipid profile in patients with metabolic syndrome? A. Increased carbohydrate intake. B. Increased omega-3 fatty acid intake. C. Increased protein intake. D. Increased sugar intake. Answer: increased omega-3 fatty acid intake. Rationale: increased omega-3 fatty acid intake is effective in improving lipid profiles in metabolic syndrome, helping to lower triglycerides and increase HDL. Increased carbohydrate intake, option A, protein intake, option C, and sugar intake, option D, would not have the same beneficial effect on lipid profiles. 80. Which of the following conditions is a common comorbidity associated with metabolic syndrome? A. Chronic fatigue syndrome. B. Obstructive sleep apnea. C. Gout. D. Osteoarthritis. Answer: obstructive sleep apnea. Rationale: obstructive sleep apnea is commonly associated with metabolic syndrome due to shared risk factors like obesity and hypertension. Chronic fatigue syndrome, option A, gout, option C, and osteoarthritis, option D, are not as closely linked to metabolic syndrome.